Ladies and gentlemen, dear friends, welcome at our webinar on behalf of the European Society of Gynecology. As you know, the Society is starting with this series of webinar, just also to promote the development of science and culture all around Europe, and to remind you that we will have our next Congress next year in March in Riga. Today, the webinar will be devoted to something which appear very common and existing since forever, but which still is now open to a lot of new possibilities and new development and new science. And we have the pleasure on menopause vasomotor symptoms, risk and treatment updates to have two fantastic speakers, Professor Tommaso Simoncini and Professor Herman Depypere. I will as you know, I will just present who they are. Tommaso Simoncini is professor of obstetric gynecology at the Department of OBGYN of the University of Pisa. And he has published a huge number of papers in high-impact scientific journal. And Professor Simoncini is past president of the European Menopause and Andropause Society, president of the International Society of Gynecological Endocrinology, and executive secretary of our society, the European Society of Gynecology. He is board member and past executive secretary of the International Menopause Society and fellow ad Undem of the International Academy of Human Reproduction. He is associate editor of Maturitas and of Gynecological Endocrinology and an editorial board member of the Journal of Endocrinological Investigation. Professor Herman Depypere is professor and head of the clinic of the University Clinic of Ghent, Belgium, and current president of the Belgian Menopause Society. He is associate professor at the Laboratory of Experimental Oncology, and he recently published on Alzheimer's dementia prevention with menopausal therapy and published the first phase 2 trial on NK3 antagonists to treat vasomotor symptoms, which is the today topic. And then, dear friends, I have the pleasure to invite Professor Depypere to start, because Professor Simoncini have not yet reached the stage 3 position. And then Herman, I think you can start, and then Tommaso will make a presentation after. Then I leave you the screen, and then you can share your slide. Thank you. Thank you very much. Thank you very much.
So thank you very much, Professor Genazzani, dear friend Andrea. So we have been collaborating, and you have been a very successful organization of a lot of things on menopause. And so it's with my pleasure I will present the study on the vasomotor symptoms. And as you said, there is a lot of new things that are going on in menopause symptoms. You know that we did a publication on the figures of the Belgian people, but Professor Genazzani did the same study on all European countries, showing in fact that there's a very high similarity between women all over Europe. That is to say that about 70% of women have vasomotor symptoms. Sometimes they are very extreme, so extreme that women have to stop their daily functioning. Sometimes they are mild, that women perceive the vasomotor symptoms but don't have to stop their daily job. And sometimes they are very weak, so that they sense the vasomotor symptoms, but it doesn't bother them too much. But basically, it's interfering with a lot of women. So these vasomotor symptoms have, in fact, complaints that do women to make them sweat without any physical activity before it. So basically what happens, there is now a very high increase of knowledge on the vasomotor symptoms. And we know that in our brain, in the hypothalamus, there is an infundibular nucleus where there are candy neurons, and these neurons are a bit neurons that coordinate a lot of factors in our brain. So they may react on hormones, they may react on odors, they may react on other external factors. And from these candy neurons, there are a lot of projections all over the brain. The projections may be to the hypothalamus, to the axis between the hypothalamus and the hypophysis, but also there is a projection between those candy neurons and the median preoptic nucleus. In fact, these candy neurons, they can produce kisspeptin, which is a protein. They can give endorphin and dynorphin, and they can also produce neurokeptin B. And what happens, that's when women become menopausal, there is a substantial drop in estrogen, and due to the fact that there is a substantial drop in estrogen, these candy neurons are a bit dysregulated. So they are overactive and they produce more neurokinin B. And these neurokinin B molecules will bind on neurons of the median preoptic nucleus, and these are the neurons that regulate, in fact, the vasomotor symptoms in our body. They control the constriction or relaxation of the blood vessels. They control the sweat glands. So in fact, if the candy neurons are hyperactive, they make, in fact, the neurons of the median preoptic nucleus hyperactive, and so the thermoregulation is dysregulated. So what happens? It has been seen in many animals. It has been seen in post-mortem sections of women that these neurons, these candy neurons, become hyperplastic, and so there is a hyperfunction, so producing more neurokinin B, making those median preoptic nucleus neurons hyperactive, and so the thermoregulation is in fact dysregulated. That makes to say that women, since they are too hot, and say they produce sweating and vasodilatation to release the heat, or they may be too quick, too cold, so they causing vasoconstriction and shivering, and as such the thermoneutral zone in which a normal person would function is narrowed, and so women have too quickly the sense of having an excessive temperature, or they sense it too quickly that they have cold, and as such this regulation causes these vasomotor symptoms. So this is a signs that have been evolving quite quickly, and this is really well studied now. So, in fact, as Professor Ghenazani mentioned, we were in fact the first to publish in clinical data using FDA regulations. There were some NK agonists that interfered directly with the neurokinin B producing cells. So if estrogen drops in women after menopause, these cells are hyperactive. Well, if they produce more neurokinin B, well, if you have antagonists against that hyper secretion of neurokinin B, then in fact these cells are becoming normally regulated again. So we had the pleasure to produce the first study using FDA standards, because the first molecule that was done was MLA and it was published in the Lancet, but it was not according to FDA regulations. So what we did, we had a randomization of 80 women having the drug taken orally twice a day for 12 weeks. And so as such, we could, in fact, since it was randomized, having two perfectly well-balanced groups, taking or placebo, or twice a day taking a neurokinin antagonist. This is in fact a very simple neuropeptide that can be taken orally. It's easy to take, and in fact this study reports on the study on that. And what we saw, that if we gave women neurokinin antagonists, and the other ones had placebo, so we didn't know what we gave, but it became immediately clear that some women say, oh, I have so many complaints, and now within a week, the complaints are gone. And so in certain women, they say that even in 40 women in the group that was taking the neurokinin antagonist, in week 4, 0 hot flashes anymore. And they were all women with very, very severe hot flashes. So it showed that this product is in fact very well, is easy to ingest, and it's working within 1 week. And if you see, the controls have, like we always see in placebo, we have a placebo effect, but the effect of the active molecule was much, much more substantial and was highly significantly better. Then not only the mild and the moderate, but also the severe hot flushes were substantially improved as soon as week 4, and especially after week 6, after week 12, was 77% reduction. And all the questionnaires on quality of life, on sleep, on mood, concentration, sexuality were all better and highly significantly better in the group that took these NK antagonists. And so even the quality of sleep was substantially improved in the group that were taking vasonimitant. And so also the green climacteric scale, which is a sort of a standard scale assessing psychological, somatic, and libido and vasomotor symptoms, again was substantially and significantly improved using that drug. All the Sheehan disability scale, interference with work, social activities, days lost at work, unproductive days, again, this product was really doing a very, very good job. So what struck again is that, in fact, we could a bit predict who was going to respond and who is not going to respond. And we saw that the women that were having a high reduction of vasomotor symptoms, they were the ones that suppressed LH very, very dramatically. So, in fact, we had a sort of an assessment, because if the LH was very low, we saw, in fact, that the complaints were substantially reduced, showing that these candy neurons that produce kisspeptin, dynorphin, and neurokinin B have projections not only at the thermoregulation, but also on the axis of the axis between the hypothalamus and the hypophysis. So, in fact, these neurons also regulate the production of LH and FSH. So, to see, because it was the first phase 2 trial, and we knew that from the previous study of the Lancet paper, there were some issues with liver enzymes. So we were carefully monitoring these liver enzymes and showing, in fact, that there were no real issues, even at those high doses. So, in fact, we were the first to show that it was a very efficient drug, it was well tolerated, and it could be validated with plasma LH, and in fact, it had a clear safety profile. From that study onwards, where we used twice 90 milligrams per day, there was a dose finding study that was done afterwards, having 60 milligrams, twice 60 milligrams, twice 30 milligrams. So all the dosages was found. And then for the final phase 3 trial, in fact, 2 dosages were selected, 30 milligrams and 45 milligrams once per day. So that means that is 6 times less than what we used in our first study. These studies were the Skylight 1 and Skylight 2. You can wonder why they did 2 identical studies. Why couldn't they do 1 big study? That's because of regulations that order that there should be 2 independent studies to show the effect. That's an FDA requirement to have a product commercialized. So the Skylight 1 study is basically doing the same what we did in the phase 2 trial, but with two dosages, 30 and 45, and of course with longer follow-up and with a higher number of women. Why? We had 40 women in each group. This study randomizes placebo, fezolinetant 30 milligram, fezolinetant 45 milligram for 12 weeks. And then after 12 weeks of treatment, then there was an extension for another 40 weeks with the sole purpose of seeing whether there was an effectiveness that was going to go on, that there was no sort of resistance to that molecule, and of course with the issue of having a safety record in a larger number with a longer follow-up. So of course these were women that were healthy between the age of 40 and 65. They were all in menopause, and menopause was defined as 12 consecutive months of amenorrhea, or 6 months with an FSH above 40, or of course, if they had had an ovarectomy 6 weeks prior to that. Then, of course, they all had to have severe vasomotor symptoms, 7 to 8 per day, 50 to 60 per week, which is a sort of a common criteria to include women to have a study on vasomotor symptoms. Of course, they had to have a normal gynecological examination, and there should be no oncological issues in these women. And of course, there should be no thickness of the endometrium assessed or prior to the study entry. Then exclusion, because there was some issues in another molecule on the liver enzymes. They were really focused on liver enzymes and to assessment on the liver enzymes. So there was an exclusion. There should be no other medication involving in the metabolization using CYP12A. And then, of course, no malignant tumors, no hypertension. So there should be women that have a normal liver function. And as such, these women were recruited. The endpoints were, of course, looking at sleep quality, looking at the vasomotor symptoms, and of course, also on the severity, the frequency of vasomotor symptoms, on the quality of life, and on the assessment of the severity of adverse events. So this is the first Skylight 1 study. You will see in a few moments, we have the Skylight 2, but it's basically paste copy, but is an independent study. So 2,205 women were assessed for their eligibility, and 527 women were enrolled. So a lot of women were excluded because of issues like the exclusion issues. So 175 women were assessed assigned to placebo, 176 assigned to fezolinetant 30, and then the other group was to fezolinetant 45. Again, 30, that's 6 times less than the study we used. Thus, in fact, having no real issue in our study, and having in the other issues with the dose finding, 30 and 45 had effectivity in those studies and had no interference with liver enzymes. So in fact, 152 completed the 12-week period, and then that was the nice thing about the study. After the completion of the 12 weeks, women were again randomized to have the active product, because it's not ethical to demand women to have a study for 1 year where they have such a high frequency of vasomotor symptoms, to have them in a placebo group for 1 year. And then, of course, after the 12 weeks, both groups completed, had an extension to the 1 year period. Of course, that's placebo controlled. You can see from that table here that there was no difference in race, ethnicity, weight, BMI, smoking status. In fact, there was a very well-balanced study. Looking at the change of the frequency, you see that even after 4 weeks, you have a reduction of the severe vasomotor symptoms and the frequency. and you see that it continues up till 12 weeks. Then if you see the change in severity, you again see that not only the frequency, but the severity is improving. Because it's very important to realize that Fesolinitant at those small doses really reduces the severe hot flashes, but hot flashes that are moderate or are very mild may not be reduced as much, but they do not bother women. It's the severe hot flashes that are important for the quality of life. And as such, it is, again, as we saw in our study, the impact of having those treatments is very quick. Even after 1 week, you see that there is a clear separation between the curves, and then it is very constant. And you would say, oh, there is a quite good influence of placebo, but of course, you see that the placebo effect will not persist for too long. It will persist for 12 weeks, but after a while, we see a pickup that the placebo effect goes away. But here you can see that there is a substantial decrease of the severe vasomotor symptoms, thus the bothersome symptoms, and it maintained during 12 weeks. Again, you see as well as the severity is reduced, and then you see that women had, in fact, more than 50% reduction of their symptoms. And then after the initial 12 weeks, the placebo women were extended to have or 30 or 45, and you see again that very quick reduction of the vasomotor symptoms, severity and frequency, and that's the effect persisted for 52 weeks. It's not that women become acquainted to the product and that the effect goes away. No, it really is a persistent effect. Of course, these are new molecules and we will have to learn to work with it. Of course, Professor Simoncini and Professor Anzani, we have a lot of experience with hormonal treatment, and it doesn't work. We can increase these hormonal treatments, but of course, I think we will have to learn to work, and sometimes I think we will have to give twice 30 in these women as well to really further substantially reduce it. But basically, the quality of the symptoms is better. In the first study, the sleep was not significantly improved, but that's because the medication is taken in the morning, and perhaps in some women it was worn out because we gave twice, once in the morning and once in the evening, and that's the reason why in our sleep it was better. So it may be that, and that's the reason why in that first study it was not improving significantly the sleep quality. In the second study it does, but in the first study it was not. So of course, safety studies, because there's a new class of molecules, there were some issues with other molecules. So in that respect, it was well studied, and you will always be surprised that if you do a placebo study, even in the placebo, there was adverse effects in 45% of women. So, of course, all mild adverse effects are reported, but the main point is that there was no substantial difference between placebo and the two groups of fesolinitants. Liver issues, which were very important. Again, there was no difference between the placebo, fesolinitant 30 and 45. And what is very interesting as well, it is not that this is 2 and this is 4 or 5. This 30 is not better than 45, showing that increasing the dose is not detrimental. So that was, in fact, showing that the issues like augmenting the 3 times ALT and SAT was not occurring in that group. So what is the summary? It is showing again that this fesolinitant in both groups were improving quality of life, were substantially reducing the severe vasomotor symptoms. There were no issues on adverse effects that were really bothersome. So in fact, this was a very good safety profile. The Skyline 2, we can be very briefly about that, is basically another study doing the same endpoints, but in a different population. But as requirements for the FDA, 2 studies should have been performed, and that's the reason why the study Skyline 2 was initiated. Again, same design, placebo, 2 groups, the same group, with the possibility of extension to 1 year. Again, if you look at the age group, the placebo, ethnicity, race, weight, hysterectomy, oophorectomy were the same basic results, showing again the frequency was improved, showing that the severity was improved, and showing again in the extension that after 12 weeks, the placebo were extended to one of the groups, showing again that from that moment on, there was a rapid decrease, and in fact, it was a very constant reduction of the vasomotor symptoms frequency and severity. Again, as well here, there was improvements in the main quality. There was an improvement in the sleep. So in fact, if the study are going to be joined, that is going to show that the results on sleep quality is indeed improved. And then again, the drug-related adverse events were similar in the vasomotor 30 and 45 group compared to placebo. And then again, the liver enzymes, which is always to be carefully monitored, and showed that there was no issues in both groups concerning liver enzymes. So summary and conclusions for the second study was in fact the same, that it was a very efficient drug. It worked very quickly. There were no issues on the safety. And in fact, there was a clear improvement of the sleep quality. And so there was no issues on extension on safety. So in summary, we are happy that there is now a very good alternative for hormonal treatments. We have a good alternative treatment, but in the old days we had every other product, a herbal med product. We had other psychological drugs, but now we have something that is working as good as hormonal treatment for the vasomotor symptoms and for the interference of sleep. But we do have to realize that this is a product, because we studied it in 2016 and 17 and 18. So we have not the 60 years of experience like with hormonal treatment. It is good for the vasomotor symptoms, but it will not interfere with bone preservation. It will not interfere with the vaginal mucosa. So we have to learn to work with these drugs, and perhaps we can use in the future very low doses estrogen in the prevention of osteoporosis in lean women or in women with issues of familial osteoporosis, together with a drug like vasomotor for vasomotor symptoms. So it will give you us a new tool to create an improvement of quality of life in menopause. And we will be able to use that in women that cannot take hormones, like in women with breast cancer, or women that opt not to take hormonal treatment. So it is a very new class. It can be taken orally. It's well perceived, and I think we will have to have more experience. But the drugs are now available commercially in Europe, and as such, I think it will be beneficial for the quality of life of women. So I give my word back to Professor Ghenazani to introduce Thomas. Thank you very much.
Thank you, Herman, for that beautiful presentation. The data was clear, the results were clear, and also in your last commentary, all the possibilities that you are now facing the future. And then I thank you, Tommaso Simoncini, of being with us. I have already introduced you before. And if you can share your screen with us, we can start with the presentation. Tommaso will speak about vasomotor symptom, a marker of postmenopausal risk. Thank you, Tommaso.
Okay. So I'll follow up to what Professor Depypere has talked about. So new treatment for vasomotor symptoms by trying to give you a view of why this could be so important, why it is so important in general to consider vasomotor symptoms. So these are my disclosures. And so let's start from vasomotor symptoms, how they're generated and why they might be a very important marker of future health for women at the time of menopause. Vasomotor symptoms are probably the best known example of what happens when hormones change, and therefore the brain becomes very, very complexly deranged in some ways, in ways that have an impact not just on the regulation of the hypothalamic pituitary ovarian axis, but also on the regulation of things that happen particularly in the hypothalamus. This is the hypothalamus. Let me present you the hypothalamus. I'm sure you've all studied the hypothalamus and how it works. This is really the center of not just reproduction, but also vasomotor symptoms, thermoregulation, thermodispersion. So it's a key area that you have to be aware of in terms of the anatomical boundaries, the neurochemical connections, when you want to understand the biochemistry of hot flashes. And hot flashes are a big problem. Hot flashes are something that is related to the changing sensitivity of a specific woman in her thermoregulatory pathways. And these pathways are the pathways that control heat conservation and, for hot flashes particularly, heat dissipation. So it's like if you have a reset in your home thermal controller that changes the way that you react to the changes in the external temperature. So this is the hypothesis that was generated by Friedman in the late 90s to explain hot flashes. So in white, you see the thermoneutral zone. So this is the area or the range of temperatures to which a woman's body reacts by being neutral in terms of either controlling or dissipating heat. The blue area shows the shivering threshold. So it's when the environment gets cold. So there's the need to preserve body heat. So one person, a woman in this case, starts shivering when the temperature goes below that threshold. Now in yellow, in the upper part, you see the sweating threshold. So when it gets very hot, body temperature gets over a certain threshold, and then our sensor, our hypothalamus, has ways to control this and to induce us to sweat, so to disperse, to dissipate temperature. Now, this is very much the area, the reason why at the menopausal transition, women start having hot flashes. So they don't just simply sweat, they flush. And flushing means a different type of sweating. It's not just sweating. It's a very complex thermodispersion reaction starting in the upper trunk and in the face, accompanied by sweating and then followed by shivering afterwards, and with an increase in heart rate, which is very typical. So what happens at the time of menopause? The thermoneutral zone becomes thinner, smaller. So the range of temperature that allows a woman not to shiver or not to sweat, or better, not to flush, becomes smaller. So it's much more common for a woman, particularly in the sweating zone, to start flushing. So there's a much higher facility. So when this happens, we have a lot of sweating or flushing events. So how does this happen? So the thermoregulation stays in the hypothalamus, but the thermoreceptors stay in the skin. So the skin has nerve terminals that are made to feel the heat and to send a neural signal to the medial preoptic area of the hypothalamus, where most of the controllers of the thermoregulation and of reproductive axis stay. And therefore, the reaction is vasodilatation, peripheral vasodilatation. So there's heat, the skin senses it, it says it to the hypothalamus elaborates this information and drives the skin vasculature to dissipate heat through vasodilatation and sweating. So where does this controller stays? Where's that regulatory system that gets deranged at menopause is located? It's actually in the medial preoptic area, as I said before. And there's a lot of pioneering research that has led to identifying this area, and particularly in identifying a specific set of neurons, which we now identify as the KNDy neuron, because they express kisspeptin, neurokinin B, and dynorphin, so KNDy, which of course is a nice name. And as you can see in the papers that are quoted in the slide, you see that if you activate these neural pathways, you can induce skin vasodilatation. If you block the transmission through the medial preoptic area of the hypothalamus, you can block the effects of skin warming on vasodilatation. And actually, and this is true also in humans, if you have lesions in the medial preoptic area, you have hyperthermia. So this is really the area that our body, men and women, use to control our reaction to heat. So let's look into a little bit more detail how this is actually structured, because this is important to understand the genesis of vasomotor symptoms, and therefore to understand a little bit more in depth how those drugs, neurokinin receptor antagonists that have been explained and shown by Professor Depypere work. So again, this is the medial preoptic area at the basis of the hypothalamus. You see the connection towards the anterior pituitary. So when you have the signal from the skin to say that there's too much heat and the medial preoptic area starts sending peripheral signaling towards dissipation, what happens is that the same neurons, the KNDy neurons, are also activated. And once they're activated, they stimulate the release of LH and FSH. So there is a common regulation between heat dissipation and stimulation of the anterior pituitary. So the KNDy neurons are those neurons that stimulate the GnRH releasing neurons, and therefore end up with increasing LH and FSH synthesis. So these are the neurons, the KNDy neurons, and their relationship. So these neurons are those that mediate both heat dissipation and GnRH secretion. And surprise, surprise, you may not have thought about that. When you stimulate GnRH synthesis and LH and FSH synthesis during fertile life, you have an increase in estrogen amounts. And estrogens block KNDy neurons, and therefore they stop the synthesis of LH and FSH by inhibiting the GnRH release, but they also decrease heat dissipation. So it's very interesting to now think that menopause is a situation where this system, so the KNDy neurons that stimulate both GnRH and heat dissipation, change. Why? Because the estrogens are lost. They decrease. So you don't have this inhibition on candy neurons, which therefore leave the generation neurons hyperstimulated. And indeed, you have an increase in the synthesis of LH and FSH as a sign of menopause. But you also increase the stimulation of heat dissipation. Actually, if you look at the hypothalamus, at the medial preoptic area of women after the menopause, as compared to women before the menopause, you see that these candy neurons are overexpressed. So they increase in size and in numbers. So it's very important. So menopause, with this loss of inhibition by estrogen, increases the activity of candy neurons, which turns into enhanced GnRH secretion and thermodispersion, therefore vasodilatation, therefore hot flashes. And this is very important. I like to quote this very nice, intriguing review article by Roberta Diaz-Brinton, who's a very talented scientist and a member of the board of the International Society of Gynaecology, that has developed over the time this concept that menopause is not just a hormonal change, it's a neurological transition state. Why? Because the fact that you lose estrogens induces or is associated with such complex changes in the hypothalamic function, and actually changes that are also found well beyond the hypothalamus, that make the brain of a woman after the menopause work in a different way. And this is a very long journey, because menopause is nowadays in industrialized countries is not a short period in the time of a woman's life. It's a long period of life. And if you think about hot flashes, as hinted to by Professor Depypere before, well, hot flashes are not necessarily something that goes away quickly. This happens in about half of the population. So there's a fourth of the population that doesn't really have hot flashes. There's a fourth of the population that has a transient hot flashes which disappear over time, but about 50% of women have severe hot flashes that can last up to 10 years after the final menstrual period, and 25% of women never stop having hot flashes. So this is a huge number. And this is data coming from the SWAN study, longitudinal study, looking up to 15 years after the menopause, and being able to solidly qualify this concept. So the issue here that I would like to raise is whether hot flashes are just symptoms. So what we have discussed about the changes in the hypothalamus because of the change estrogen levels, are these just something that modify the way that a woman perceives heat and cold in the environment? Is it just an epiphenomenon that can be addressed by just changing the environmental heat, which is actually one of the good strategies to fight hot flashes in women? Or are they something more? Now let's look at how hot flashes correlate with health. It's a long, it's the concept that there's a connection has been long understood. And it's not just for quality of life, because women who have hot flashes forever have a very poor quality of life forever. But it's also for the implication for physical health. For instance, both the WHI and the HERST trial, which are very large, randomized, placebo-controlled intervention trials, the WHI had also a longitudinal observational arm, which we don't discuss too much in our congresses, but they identified that elder women with baseline hot flashes were those women where there was a concentration of cardiovascular risk and a relationship with hormone therapy use. So let's look at different items. For instance, cognitive function. It's really well understood. Pauline Mackey has studied this for several years. She's a neurologist in the United States, and she's been able to show that in different times in a woman's life, particularly those times where there's significant hormonal changes or reproductive events, there's a relationship between brain function and hormones. And now, what Pauline shows in this study published several years ago now is that there's a strict relationship between the prevalence of hot flashes, so a woman having hot flashes, and her cognitive function, as measured by the ability, the performance in verbal memory recall tests. So you give her a number of words to recall and how many she recalls and how precisely in the order that were given. So these are tests that are given by neurologists in order to test cognitive function. So if you have more hot flashes, you are less good in cognitive performance tests. Symptoms of depression, the risk of depression and or irritability, so anxiety and other mood disorders are strongly associated with menopause symptoms, particularly with the hot flashes. The odds ratio from depression is more than 4 times higher in women who have hot flashes as compared to those women who don't have hot flashes. Let's look at something that might be less logical. So far we've looked at the brain. Now we're looking at the bones. Look at BMD, bone mineral density. This is a study of women had across the nation. More than 2,000 participants followed over the menopausal transition. And what they saw in the study is that perimenopausal, premenopausal, or postmenopausal women differ in bone mineral density, and they differ only for those women who are actually having hot flashes. So women with hot flashes tend to have lower bone mineral densities. Cardiovascular disease. This is really the big issue because we all know that cardiovascular disease is the killer in the female gender. So there's a lot of studies. Rebecca Thurston has been the leader in a number of researches over the last 15 years to show that subclinical cardiovascular disease is associated with the prevalence of hot flashes. So women with higher rates or severity of hot flashes have more subclinical cardiovascular disease, which means higher intima media thickness or coronary calcification in the absence of disease. They tend to have higher blood pressure. They have to have worse lipid levels. They are more insulin resistant compared to women without hot flashes. Their autonomic nervous system and their markers of inflammation and hemostasis are worse. So there's a long list of very important things that correlate with cardiovascular disease, which are found to be more strongly present in women with hot flashes as compared to women without hot flashes. This is actually clinical data. This is the data from the SWAN study of women across the nation again, where women were analyzed based on their hot flash frequency. This is postmenopausal women. They had hot flashes and they were measured within the past 2 weeks, whether they had an average of 1 to 5 hot flashes per day or more than 6 per day. So you can see that there's a direct correlation. Those women with more frequent hot flashes had a much higher odds rate of developing hypertension. So those with more hot flashes were those women who more frequently developed hypertension compared to those with less hot flashes. And again, this is the same as measured with subclinical cardiovascular disease. So it's intima media thickness measured in women without hot flashes, the known left bar, women with 1 to 5 hot flashes per day, or women with 6 or plus hot flashes per day. You see that there's a direct trend. So the more hot flashes you have, the more subclinical cardiovascular disease you have. And let's look at duration of hot flash, which is another thing. For how long have women had hot flashes? And does this link to surrogate markers of heart disease? For instance, aortic calcification. So this is the aortic calcification score. It's a measure of how much calcium women have in their aorta. And you see that if women reported in less than 50%, never the known bar, or less than 50% or more than 50% of the times they actually came to the outpatient service that they had hot flashes, So they had a longer, more consistent history of hot flashes. Those women with a longer story of hot flashes, with a longer duration and a more consistent presence, they had a much more represented aortic calcification. Sleep. We all know how sleep is disrupted by hot flashes. We all know that sleep is disrupted by menopause. But what might be less known to you is that sleep disruption, insomnia, awakenings are very important, one of the key predictors of future cardiovascular disease and of hypertension and of diabetes, all the things that relate to cardiovascular disease as well. So this is very important because, of course, sleep disruption after the menopause is not just due to hot flashes. It's more complex. Also, women that do not have hot flashes tend to have a worse quality of sleep after menopause. But in those women without flashes, the disruption in the depth, in the stages of the sleep, so the amount of time that is spent in REM sleep is less. And the blood pressure during the night tends to be higher. So all these things are very, very important. And let's not let's not go into those conditions which are more severe, like sleep apnea syndrome or restless leg syndrome, that affect very commonly postmenopausal women. So this is another study, the MS Heart study. It was published by Rebecca Thurston in 2016. You can see that in this study, shorter sleep time was associated with higher subclinical cardiovascular disease. And again, it's in postmenopausal women. So the shorter the time spent sleeping, the higher the amount of plaque index these women had in their intima, in their carotid arteries. And look at this study. This is, again, very interesting. There is a synergistic effect between short sleep and hot flashes related, again, to intima media thickness. So if you sleep less than 5.5 hours on an average every night, and you have hot flashes, actually you have more than 2 hot flashes during the night, then your risk, or better, your prevalence of a higher, your thickness in the intima media is much higher than in those women who have less hot flashes. So it's not just sleep disrupted, it's also sleep and hot flashes. So it's 2 parallel paths that lead to cardiovascular disease. So I'm heading towards the conclusion to remind you again that not all women have vasomotor symptoms at menopause. But if you couple the type of phenotype of those women that undergo menopausal transition based on whether they have for a very long time or for a short time on flashes, and you couple that with cardiovascular disease, there's a perfect correlation. So women that have hot flashes for a very long time are those women that have a much higher thickness in their intima thickness, together with those women that have hot flashes that start very early, even if they stop later on, but when they start very early during the menopausal transition. So, and they differ towards the other groups, the other phenotypes. So it looks like the way that women develop hot flashes tells us a lot of things about their adaptation, their cardiovascular adaptation to menopause and aging. Now, I showed you so far only data on surrogate markers, calcifications, intima media thickness, blood pressure. These are not hard endpoints. Now, let me show you some hard endpoint studies, because this is really important to be mentioned. We have studies that show that hot flashes, vasomotor symptoms are associated with the cardiovascular mortality. This is the WISE trial, again published by Rebecca Thurston, and you see these 3 groups in the graphs. This is the percentage of women that, and the relationship over several years on the chance of having of dying, actually, not having cardiovascular disease, of dying because of cardiovascular disease. Then you see that those women who had never vasomotor symptoms, they do much better than those women who have a vasomotor symptom at the age onset of less than 42, as compared to those who had an onset over the age of 42. So there's a clear relationship between how early and for how long you have vasomotor symptoms and your likelihood to die of cardiovascular disease. And again, this is the SWAN trial that I mentioned before as well. This is the rate of cardiovascular disease expressed in two different graphs. On the left side, you have the frequency of reporting of having hot flashes at the times of the outpatient visits. So those women who said in more than 1 out of 3 times of their access of the outpatient clinic that they had experienced vasomotor symptoms, the rate of having a cardiovascular disease event was much higher. And again, on the other side, you can actually tell that it's also the frequency of vasomotor symptoms during the day. So when they reported having no vasomotor symptoms, or 1 to 5 vasomotor symptoms per day, or more than 6 hot flashes per day, which is the red graph, then you see there's a clear step up in the rate, in the likelihood of developing a cardiovascular disease event. So I think there's really room to panic, or better, to be alarmed, to see in hot flashes a red flag that we as physicians need to take care of. And as a take-home messages, I like to re-stress that menopause is a time of profound changes. And it's not just hormonal changes, it's brain changes, it's cardiovascular changes, it's metabolic changes. And the early identification of those women who are at added risk is important to enact appropriate lifestyle and pharmacological preventive strategies, which are the key to prevent brain degenerative disorders over time, bone changes through physical activities and through healthy diet, and cardiovascular disease as well. So we need, however, to be more aggressive in those women at risk. So how do we identify women who are at risk? We can identify women at risk for sure by the presence of hot flashes, by the precocity of hot flashes, and by the severity of hot flashes, because these are clearly markers of future health risk. So hot flashes are really a big deal. So we can't just trivialize hot flashes, and we actually have to give a great importance to the presence, to the precocity, and to the severity of hot flashes, because they allow us to identify those women that we need to follow to treat with hormones, with non-hormonal treatments, with diet, by suggesting they engage in healthy physical activity, so to decrease the future health risk over time. So thank you so much for listening to me. I hope it was clear, and I think we'll have some discussion now.
Thank you very much, Tommaso. Thank you for that beautiful presentation. We are now ready for the discussion. We have received already a series of questions, and okay, I would like to start one. This is from Claude Hughes. Herman, I think it's for you. Is there post-approval experience of giving the 45 milligram dose in the evening or at the bedtime and seeing sleep improvement?
I think it's a very good question. I think the half-life is covering around half of a day. So I think maybe if the main issue is sleeping problems, it would not be a bad idea to shift and to give that during the night. So I think, or if she complains during the day and during the night, I think we will be learning to work with it, and maybe give it twice a day as well. So I think we are still in the safety range. But I think it's a very good point. So, we have to address what is the main issue. I think we saw that the placebo works as well. So I think if women are reassured that the vasomotor symptoms is not a cardiovascular problem, so maybe a bit of placebo and the effectiveness of giving it at night, maybe a sort of thing. But I'm pretty convinced that in the future, women will have to have twice a day again if they need to. But that's something we did with hormonal treatment as well. Eh? We start up with a low dose, and if not sufficient, we may increase a little bit, and a small increase may be enough. So we have to tailor it down, and I think with these drugs, it will be the same.
Thank you. Tommaso, do you want to add something about the effect of placebo? Because always we are astonished by how placebo can be efficient in an individual who was already suffering from years of the same symptoms.
Yeah, it's a complex issue. It happens in all the studies on hypertension, even the studies on blood lipids. So it's really the best hypothesis is that when a woman or a man as well enters a clinical trial, which is a complex set of interventions, of accesses to the hospitals, of being taken care of by physicians, the perception of symptoms changes, and this is very common. So it happens throughout all the studies. So it's just so. So this is why we do prospective randomized placebo-controlled trials, because we know that placebo will be there, and we need to be able to measure placebo. Yeah.
Thank you, Tommaso. And then now it's a more specific question from Aluk Timur. If wonder if obese or overweight women have the same vasomotor symptom responses, since adipokine may have effects on reproductive system.
Yeah, maybe I'll take that. So there was traditionally obese or overweight women have been considered to be protected at the time of menopause because their ability to synthesize peripherally estrogens from adrenal androgens and so and so. So we are aware that the peripheral levels of menopausal women that are overweight are higher than in women that are normal weight or with low weight. But this doesn't tell the story, so it's much more complex. The frequency of hot flashes and some of the conditions, particularly brain conditions, are not associated with body weight. Actually, there's some studies that show that overweight women have higher rates of hot flashes. So it's all in the brain. So whether this has anything to do with brain-derived hormones like adipokines, it's not been studied to my knowledge, so it's very difficult to say. But it's very linked to the phenotype. So each woman has her own way to transition towards menopause and her brain adaptation to menopause.
Thank you. And then Herman, it's a question for you from Shaibu Bello. The response, he mentioned the data that you have presented. The response tends to flatten out and become steady. So what is the effect of discontinuing drugs after 52 weeks? This has implication for possibility of interval therapy or lifelong therapy?
I think the studies show that the effect doesn't wear off after 30 weeks, or it is maintained at a very stable level even after 1 year. So I think it's like hormonal therapy, and so maybe after a few years we can stop and look what happens, but I'm pretty convinced that as soon as you stop, the effects will reappear. So I think this is a medication that will have to be taken for quite a long time if you prescribe it. It's not that you reduce vasomotor symptoms for a couple of months and then you can stop. I think they will reappear. That's pretty sure. But as soon as you stop the NK antagonist, the hyperactivity of the candy neurons will reappear. I'm pretty convinced about that. It may be even a bit higher. So maybe a rebound, I don't know, but that I expect that.
To be studied. And then Tommaso, I would like to thank Jean-Michel Fouadard is with us, and I would like to thank him for bringing that question. He writes, do we already know the cause of the correlation between hot flashes precocity, severity and frequency and risk of cardiovascular complication? For the proper treatment of such high-risk women, are the NK3 receptor antagonists sufficient, or is it preferable to use estrogens?
Well, first, let me greet Jean-Michel and thank you for listening to our webinar. It's a pleasure to know that you're there. No, we don't know the link between the severity, precocity, or even the presence of hot flashes and cardiovascular risk. Some of the things that we know, like sleep disruption, peripheral instability in the vessels that might be causes of hypertension or facilitators of development of hypertension have a rationale to explain this link, but the truth is that it's an association. So we know that women with hot flashes then have all these cardiovascular conditions with a higher frequency. So I think we can honestly say that hot flashes are a marker. It's very difficult to answer in a scientifically honest way to say that if one takes out hot flashes without changing all the hormonal or the metabolic changes of menopause, then cardiovascular disease or cognitive dysfunction or even bone changes will not happen. So to answer the second part of your question, Jean-Michel, if NK3 receptor antagonists will be sufficient, first of all, we just don't know. And I think we cannot answer now. We might be able to answer to this very complex question probably in 15 to 20 years from now. It might be that by blocking hot flashes, if women sleep better, and this has not been shown convincingly yet, but it's logical to think that this would happen if they don't have hot flashes. So if they sleep better, maybe they have a better quality of life, maybe they have a lower incidence of hypertension, all things that are in the hypothesis right now, they might be doing better for cardiovascular risk. For now, estrogen or menopausal hormone therapy is the only treatment that has been shown to be effective in primary prevention of cardiovascular disease. So before thinking of doing some good to cardiovascular disease prevention with something new, we need to remember that we have an established treatment that works very well.
Thank you, Tommaso, for the very articulated response. And thank you again, Jean-Michel, for being with us. And now, Herman, we have a question from Ingrid Pinas. Very nice presentation, Herman. Thank you very much. My question is about treating women with migraine aura who are cautioned not to use hormone therapy. Can they safely use fezolinetant, and is there an effect on their migraines?
We did at very high doses not observe migraine. So I think the link between migraine and hormone treatment is known, and is especially if there is a lot of fluctuation, like if you stop the pill and if in the transition you have a lot of migraine, giving estrogen on a constant way, in a steady state way, is not all that much increasing migraine. But I think we all have these women that even if they look at hormones, they have migraine. I think they're not studied as a special group, but it was not the perception that the headache was increased with those medication. I think what was seen that women that took the high dose, they slept much better, and that's of course giving an excellent therapy to give some rest to your brain during the night. But so I think, but as a specific group with women with a high risk of migraine and under treatment with vasomotor symptoms, that study was not done.
Thank you very much. And then one question, Tommaso, for you is from Maria Eulalia Fernandez. Is there a relation between hot flashes severity and the proportion of decrease in estrogen?
A very good question. Indeed, most women start having hot flashes during the menopausal transition, which is a time, as you, I'm sure, all appreciate, where estrogens are not necessarily low. Actually, they very often they're higher than normal. And this is because of the high prevalence of anovulatory cycles. And what can be said about estrogen levels in this particular stage is that they fluctuate up and down in a way that is not the one women were used to up to the moment when they started losing their regular control of the hypothalamic pituitary ovarian axis. So no, there's not a relationship between severity and proportion of decrease. So it's not that if you lose more estrogens, you have higher hot flashes. And I think this is also shown by the differential responses of women, for instance, receiving treatment for breast cancer, particularly those who receive treatment with aromatase inhibitors or with GnRH agonists, which they develop profound reduction of estrogen levels. And we do see variable levels of hot flashes. Most of these women have symptoms, but it's not that they all have very bad symptoms. Some women have bad symptoms, some women have moderate symptoms. So the relationship is more complex.
Thank you. And then now, Herman, we have a nice question from Omi Oizua that I connect also with the fact that in some individuals also hormone therapy do not correct hot flashes. We have women who take hormone therapy, but still they complain hot flashes. And then Omi asks, can NK3 receptor antagonists be safely used with conventional hormone replacement therapy? Have you any experience about that one?
We have no experience, but in respect, even though in our study and that we had all the criteria for menopause, 1 year, 6 months, so the classical criteria, we had some women that did still produce some hormones in the post study analysis. And so no, there's absolutely no contraindication that you should not combine them. I think you can combine them, and I'm pretty sure it has not been studied, of course, because they're all postmenopause women. But it's well, it's a different way of interfering with your neurokinin antagonist, with your neurokinin production. I'm pretty sure that if you look, neurokinin B stimulates the production of kisspeptin, and dynorphin reduces it. And I think the way of interference with estrogen is another way. So I think they may be additive. I'm pretty sure they will not be counteractive.
Thank you. And then Tommaso, do you want to make a comment on that point?
No, I think Herman said it very rightly. So there's no information. So no study has been performed providing hormone replacement and NK3 receptor antagonists so far. So we missed that information. So we don't know whether the addition of NK3 receptor antagonists might synergize with estrogen treatment. I think it's very rational to think so, but since it's not been tried, it might be just enough to have either one or the other. So I think it's really worth trying. And on the same line, we don't even have information on women during their menopausal transition, which would be very similar to adding menopause hormone therapy and NK3 receptor antagonists. Following what we said before, most women have hot flashes during the transition. So would it be okay to give them NK3 receptor antagonists in this age range? We don't know because the registration trials have been done only in women after a year of amenorrhea or with FSH levels that were elevated and, you know, diagnostic for menopause. So apart from a very small amount of women in the trials, all the info we have is on established menopause. So it's interesting. It's a good question for the next future.
Then I have nice, nice. I have a comment from Jean-Michel and the next question from Maria Augusta Maturana. Thank you, Maria Augusta, for being with us. It's a good friend, also friend of Fred Naftolin, that we are happy of her participation. I will read that of Maria Augusta. Great webinar. Nice and great webinar. I would like to ask Dr. Tommaso a question. We have studies in literature that support the importance of hot flashes in women's health. Typically, these patients with higher cardiovascular risk are also the least likely to be selected for estrogen treatment, which is considered the most effective therapy for vasomotor symptoms. What be an alternative approach in this case? And I link that of Jean-Michel. Hot flashes are much more severe soon after bilateral oophorectomy. Are such women at much higher cardiovascular risk than women who undergo spontaneously menopause? I think this question you can have a link together. Please, Tommaso.
Well, I know, yes, I'll start from Jean-Michel's point because it clearly opens the discussion towards the question from Maria Augusta. Those women who are at higher cardiovascular risk, who Maria Augusta rightly said are generally less frequently prescribed HRT, this represents the typical error in medical practice. So this is wrong. Those women who are at higher risk of cardiovascular disease should be receiving menopause hormone therapy with a higher aggressiveness, because we know that over time they will have a big benefit. Now here we need to distinguish women with who have developed cardiovascular disease. So a woman who had a previous myocardial infarction or a stroke, these women are at risk if you provide MHT. But here we are discussing about younger women who have a family history of cardiovascular disease, who tend to become hypertensive. Those women are healthy. And in those women, prescription of HRT will decrease their cardiovascular risk. So it's really the opposite. Those women who are at a higher risk should be the best candidates for menopause hormone therapy. Now, if there's really, you know, big contraindications to HRT, which from a cardiovascular standpoint is very rare in a 50-year-old woman. Frankly, it's difficult to find a woman who has a cardiovascular contraindication to being prescribed HRT. But nonetheless, in those cases, an NK3 receptor antagonist might be a good option, at least to address hot flashes.
Thank you, Herman. And we have a question from you, from Yoldemir Tefik. Hi, thank you, Yoldemir. Happy to be with us. Is after the Skylight 1 and 2 trials were finished and the medication was stopped, were women followed afterwards and checked for the relief of vasomotor symptoms, sleep problems?
They have not communicated that wise, but that's I will ask. I don't know. I don't know. But what we saw in our study, there was a follow-up and there was a rebound. But I don't know the Skylight. It was not in their primary endpoints, so I think otherwise they would have stated it.
Okay, it's always pity that these studies are done in two selected group of individuals and we don't know nothing what happened after. I have always that kind of disappointing during my activity in the hospital. And then now, dear friends, we are at the end. I think we still have nearly 200 people with us. I would like to have a final comment. First, started Tommaso, and first started Herman and then Tommaso. Now I would like that Tommaso, you give your own, and Herman, you give the final words. Tommaso, please.
Okay, so I think that the strongest message that should come from this webinar is that hot flashes, so climacteric symptoms or being symptomatic at the menopausal transition afterwards, is to be considered an important marker of future health problems. So if we start from this very simple clinical practice pearl, we are in the position to identify women who we have to take care of. I wouldn't say better, because we need to take care the best as we can for all women, but these women really deserve attention. Maybe they deserve a stronger motivation to engage in a healthy lifestyle, in physical activity, in changing the way of life, and they might be the best candidates to receive treatments, being them hormonal treatments, being them NK3 receptor antagonists when we will have them, but also antihypertensives, lipid lowering agents. So whatever is of help to their future health, if they have symptoms, these are the women that we need to target. So if those 250, 300 persons who have listened to these webinars will remember this thing and will translate it into their clinical practice, I think it will be a very, very good effect of this webinar.
Thank you. And then, Herman, I would like that you, because you have made a fantastic talk on something which is not acting as an estrogen or as a progesterone, not through the thyroid receptor, but in another way. And as you know, unfortunately, 7.6% of the world basis women, they will suffer of a breast cancer. They had, they will have, or they still have now. Then, and they are strongly suffering of hot flashes at the menopause, strongly hot flashes during treatment, to avoid the recurrence of the tumor. And this is the real question that all of us we have in our heart. Then I would like, out of skylight, because it was not done on this patient, I would like to have your comment as Herman Depypere, a fantastic neuroendocrinologist and gynecologist too.
And we do breast surgery. Eh? So the thing is, like, we have now elinzanetant, which is another NK3 antagonist that was specifically studied in OASIS 3 and OASIS 4. So the study on OASIS 4, that's specifically in women with aromatase inhibitors and tamoxifen. That study is with elinzanetant is finished recruiting. All the women have completed their 12 weeks of inclusion and now have been offered to extend for 1 year. So the study is recruiting, and elinzanetant has already been reported as being as efficient as fezolinetant. So I think that study will show that it's safe to give them, because going for what you say, we even have the perception that women have so many complaints that they even do not take tamoxifen and not take aromatase inhibitors. They say, look, I've had my surgery, I have had my chemotherapy, I would rather die in good quality than suffer another 5 years or 10 years. So I think we have to really address that. So, but the study is on the way, and it's a good suggestion. I will suggest that elinzanetant, after they have finished the drug, they do a follow-up for another 2 months to see what happens if there is a rebound. So that's a good suggestion, Andrea. Like always, you're very inspiring. Eh?
Thank you, dear friends. Thank you, Herman. Thank you, Tommaso. Thank you for your partnership with the European Society of Gynecology, but also thank you for the passion that we were perceiving from your talk on what you are doing for women health. Then I would like to thank Biomedical Technologies for supporting us. I would like to go to the closing slide of the session to invite the people to join also our next webinar. Next webinar, also done by European Society of Gynecology, with two fantastic personalities, Professor Sophie Christine Met from Paris and Professor Andrei Milevich from Wrocław, on thyroid and reproduction, another fantastic area. And all these are done in preparation of our next Congress. Then I would like to invite all of you in the fantastic Riga, in the beautiful Baltic area, March 1922 of 2025 of the next year, we will have the European Society of Gynecology Congress in that fantastic location. And I invite all of you, and I thank Tommaso and Herman for being with us, and they have stimulated us, not only bringing information, but stimulating us to go on and to be never it's a never-ending road. Our own is a never-ending road. Thank you, dear friends. Thank you to all of you. Thank you, Tommaso. Thank you, Herman, of having dedicated your time to the European Society of Gynecology. See you all next time
Thank
at the
you.
next webinar and also in Riga.